I would like to welcome you to this webinar titled Risk Assessment Basics for the Infection Preventionist. My name is Denise Cutting, and I will be your moderator for this program. Now I'd like to introduce our speaker for the webinar. Amanda Bennett is an infection prevention advisor for the Patient Safety Authority. In this role, she serves as a resource for Pennsylvania facilities through education and developing and monitoring infection prevention and reduction initiatives. Amanda has an extensive background in infection prevention, laboratory testing, analysis and interpretation of diagnostic results, education, and regulatory standards. Prior to joining PSA, she worked in acute care settings as a molecular pathology medical laboratory scientist, point of care coordinator, and infection preventionist. None of the planners of this educational activity have relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Amanda, I will now turn the program over to you.
Hi, everyone. I'm so glad that you could join us today to talk about risk assessments. I think it's something we definitely don't talk about nearly enough, so I'm glad to get the conversation started with this. Our objectives today are to explain an infection prevention risk assessment, review the process of performing an infection prevention risk assessment, and demonstrate how to create goals based on information from the infection control risk assessment. So what exactly is an infection prevention risk assessment? A broad definition of a risk assessment is a process to identify and analyze potential future events that may negatively impact the facility, patients, or staff, and make judgments on how much risk can be tolerated when considering all of the influencing factors. A more simple way to say this is that a risk assessment determines possible events, how likely they are to occur, and what consequences they would result in. And then again, what is the facility's tolerance for such events? The results of this process may be expressed either quantitatively or qualitatively. This is a required component of an infection control plan. It helps you to identify and prioritize your infection prevention activities, and it ensures consistent delivery of high quality care. So why do we perform an infection prevention risk assessment? It's always important to stay proactive in identifying any gaps in infection prevention policies and practices. We would much rather find the potential issue and fix it before it causes harm than to only be alerted after the harm has been caused, and then we're backtracking and trying to fix things. The risk assessment also allows you as the infection preventionist to effectively allocate your resources. And we're not just talking about tangible resources like PPE, but also allocate your time and where you're going to spend your time effectively. We know that many IPs wear multiple hats within their facility, and the risk assessment will help determine how much of your time should be spent on which initiative. So to go kind of back to the first point a little bit, this process also helps promote patient safety because we're hopefully finding all of these gaps before they're causing any harm. And it's really helpful to you as the IP to give you a roadmap for the year. It helps determine your annual goals and where we're going to spend our time and our energy. So about who should be involved, I found this line from the Department of Health Infection Control Plan Toolkit, and I thought it was really well stated, so I wanted to include it today in the presentation. From the toolkit, they said, work on the infection prevention and control risk assessment should involve a multidisciplinary committee. In many cases, this is your facility's infection control committee. And while the risk assessment and its scoring can be subjective, the inclusion of many voices and perspectives can help to minimize such subjectivity bias. So your risk assessment should not be, and it certainly won't be as thorough or effective if it's not a team effort. So we really want to make sure that we are not just, sitting in our office as the infection preventionist and doing this all ourselves. So some other departments that you might want to consider working with on this are quality, risk management, your frontline healthcare workers, pharmacy, laboratory, and your facilities or materials management department. And then as you're planning or preparing for your next risk assessment, it's important to make sure that you come to the table prepared with all of your relevant infection prevention information and data. Some examples of data that infection preventionists can prepare are your healthcare-associated infection rates, vaccination reports, any reports on sharps injuries, serious event reports, any performance information that you've been tracking, all of your auditing and rounding information, and then any findings from your recent surveys. Other departments should bring similar information related to their department. And then when we get to how the risk assessment is done, some of the scoring may seem subjective, but it should be based on information from the facility, from the patients, and the community, which we're getting from everything that everyone's bringing to the table when we're doing it. So this is an example from the Oregon Patient Safety Commission on infection surveillance and quality data, and that can be useful when you think about how you're going to prepare for your risk assessment. It doesn't have to be overcomplicated. If you're putting together a chart like this, it may take some time in that first year, but then in subsequent years, all you're really doing is adding the current year's data. So if I'm looking at this, I can get a lot of information already about what this facility has been doing or where they need to focus some of their activities. So if we're looking at this, I would think that it's potential that this facility did some projects on infections in their Class 2 cases. In that line, we can see that in 2009, they started out with 12.5, and in just 2 years, they've gotten that down to 4.8. So they definitely made improvements there. It looks like maybe they also worked on some hand hygiene compliance rates. In 2009, their hand hygiene compliance was at 67%, and 2 years later, by 2011, they got that up to 77.4%. We can also see where maybe they need to work on things a little bit. Certainly MRSA infections, when we look under infections caused by specific multi-drug resistant organisms, we see that in 2009, they had 15, and then in 2011, they more than doubled up to 33. So we want to look at exactly what's happening there. Is this a change in MRSA within the community? Is this maybe some transmission they're seeing from within the facility? Is this a break in some of our practices? So that's definitely a lot to consider with that one. Another thing they may want to work on is their orthopedic surgical site infections. We started at 3.4 and are now at 6.4. And then also their employee influenza vaccination rates have steadily over the 3 years been relatively low. We see those numbers at 58%, 60%, and 57%, which are obviously not ideal vaccination rates. And then you're going to see in later slides how all of this information is useful and how we can use this information when we are doing our risk assessment. So when we look at the CDC's core infection prevention and control practices for safe healthcare delivery in all settings, it specifies that performance measures should be tailored to the care activities and the population of the facility. And we do this by using a risk assessment to ensure that your goals and the tracking measures that you're using are appropriate for your given services and population. It's important to make sure that the information and data you're using to perform your risk assessment is specific to your facility and your patients. So before we move any further, I want to make sure that we're not getting an infection control and prevention risk assessment that we're talking about today confused with any other similarly named infection prevention tools. So the first one that comes to mind would be an infection control assessment and response, or an ICAR tool. This is a tool that was developed by the CDC that systematically assesses a healthcare facility's infection prevention and control practices. It involves a lot of different modules that a facility can choose from depending on how much time they're spending or specific concerns that you may have. If you've had an ICAR done at your facility recently, the information from that can certainly be used for your risk assessment, but they are not the same thing. Another tool that I think can be a little bit confusing and has a bit of a similar name is the Infection Control Risk Assessment, or an ICRA. This is a tool that I'm hoping all of our IPs are familiar with. If you are not, please reach out to us. We are more than happy to go over with this with you, explain it to you in detail, If you've got any sort of construction or renovation project happening at your facility, we can walk through this with you, make sure that everything has been done right, especially if it's the first time doing it. So please feel free to always reach out to us for something like this as well. And then ICRA is a tool that we use to really assess a construction project to determine what mitigation strategies we would want to put in place to ensure safety for everyone within the facility. And the way this one works, you kind of looking at the type of project you have, deciding what type of construction activity it is. Then we're going to look where it's happening within the facility to determine potential places of risk. We're also going to think about ancillary places that could be affected if they're not the primary location, and then you'll get a list of all of the mitigation strategies you want to put in place before and during your project, and then also once it's complete, how to safely get the space ready to be used again. So now we're really going to get into the meat and potatoes of this presentation. My goal is to show you what's involved in the process and exactly how to perform your risk assessment. I'm really hoping that you walk away from the presentation today feeling like you're ready to start or update your current risk assessment, that you feel like you're prepared to be able to do that for your facility. So in a very basic overview, the steps of performing a risk assessment are to understand your facility and your population, develop a risk assessment template and score your risks, and then to use your risk assessment results to create a plan and goals. We're going to go into each of these into the next slides to really take a deeper dive. So when you're understanding your facility and your community, we want to, again, really assess what exactly we're working with. So when we're thinking about facility-specific information, we want to think about what services are we providing, how many operating rooms we have, what specialties we have doing procedures within the facility, the number of surgeons we have, what our staffing looks like, and what our hours of operation are. Our patient population, we want to think about the age, the socioeconomic status, health literacy, and then also culture and languages. So I think this is something that healthcare in general is getting better at, but it's something that we need to keep always considering. You know, as healthcare workers, sometimes it's hard for us to think about people who don't work in healthcare and what is their literacy. Do we need to make our the information that we're providing in other languages based on what we're seeing in the community? So we want to make sure that people are able to comply with the information that we're giving them, and we're making it as easy as we possibly can for them to do so. And then thinking about community risks, natural disasters, emergency preparedness. We would want to think, you know, during the respiratory season, thinking about our respiratory illnesses. We've all heard on the news that there's measles back in certain areas. If that's something that's impacting your area, again, we would want to be considering that as well as something that's currently going on. And with everything, you know, when you're looking at developing your risk assessment template, don't reinvent the wheel. Risk assessments are not a new thing. There are a lot of templates out there to help you develop yours. So make it easy on yourself and use the resources that are available to you. I'm going to show you two templates. This one here is from the Pennsylvania Department of Health. It gives you a really basic template. On the left-hand side, you can see different categories, and then you would fill in the potential risks. And then the rest of it is how we're going to score things to determine what our biggest gaps are. This second one is from the University of North Carolina's SPICE program. It has a bit more information for you because it actually has some of the risks already identified and filled in. You can download this one just like you can the one from the Pennsylvania Department of Health as an Excel file, and you can add and remove risks that you feel are relevant for your facility. And I would definitely encourage you to look over them and add things in and take them out depending on what you're doing at your facility. So, you know, we've got our template, we've looked at our community, we've looked at our facility and our patients, so let's identify those risks. So using everything that you know, we want to really think about anything that could possibly impact our facility, any problems or concerns. And it might help to really think about them in terms of classifying them or categorizing them. So certain ways we could do that is thinking of it in terms of patient care risks, personal risks, environmental risks, site-specific risks, or exposure risks. We can do things specific to healthcare-associated infections, where we're going to look at our risk of every type of infection that we might see. Now we're going to actually talk about how we're going to score the risks and what this means. So I'm going to use the Pennsylvania Department of Health template here to go through this. So what we do is on the vertical axis, you have all of the possible risks that you would put down that you're concerned about. And on the horizontal axis, you have the different categories we use to think about the severity of those risks and what the consequences could be. So first, we see the probability of occurrence, which is the likelihood that this risk is going to occur. You're going to review historical county data, statistical data, facility infection surveillance data. You can look at the facility services that you provide, your population that you've served, the structure of your facility, and then your geographical location as well. The next category we're going to look at is the risk impact. So this is the severity that the impact would have on the facility's patient population, also your staff and the facility itself if it were to occur. And when we're thinking about the facility, we want to make sure we're also considering any financial or regulatory consequences that could occur. And then last, we're going to consider your facility's preparedness to address or mitigate the risks so that the event does not occur. So this is your ability to detect the event, any existing infection control and prevention policies or procedures you have in place. Do we have human resources policies in place to enforce compliance with our existing infection prevention policies and procedures? Does frontline staff have access to the compliance data that we're collecting? Do we have all of our competency requirements met? Are we doing training on this during orientation or annually? We also want to see that the staff has access to all of the policies and procedures and the resources that we have available. If we have them, but the staff can't access them, they're not really doing us any good. And I just want to say here again, we don't want to forget to consider any historical data. A lot of things, or some of the things that we're going to talk about when doing a risk assessment are assumptions that we're making, but our historical data are facts that we can really lean on. So it's important to include those. And again, we don't want to create the wheel. Any information from past events should be included. And then from these results, once we have addressed all of our concerns in that last column, we're going to get a numerical risk calculated. And then what we want to do is, based on those calculations, the facility should focus on our highest scoring risks, because those will be the biggest gaps that we have to address at the facility. So we've done our risk assessment. We're seeing what our biggest gaps are. So the next thing we need to do is really set goals and prioritize our risks. So we want to work on tackling the risks with the highest scores first. If you come out of your risk assessment and you have a lot of items that are scoring high, make it realistic for yourself. Maybe you want to tackle 3 or 4 of them in a year and determine, which those are, but I would not suggest, getting yourself overwhelmed or trying to take on too many things at once. You'll be spread too thin and won't really get much done at all. So at this point, we're going to establish our baseline data, either with internal or external benchmarks. We're going to look for any regulatory requirements related to the risks that we're looking at, and we want to include all of this into our infection control plan. We want to set improvement goals and begin formulating a plan to work towards them. When we talk about goals, a lot of times we hear people talk about SMART goals, so I want to make sure we go over exactly what a SMART goal is. So the first thing we want is for our goal to be specific. We want to identify exactly what we're working on, if there's a specific population or a location within your facility that you're working on it for. We next want them to be measurable. We want to make sure that we have a way to track our progress. We need some baseline information to start with, and then how are we going to track that to see how we've done with the project over time. We want to make sure our goal is achievable. Are we actually setting a goal that is realistic? If we are looking at something like hand hygiene compliance and we know that we're currently only at 50%, we probably don't want to set our goal to be 95%. If we make our goals unachievable or too hard to reach, it's going to make people not want to work as hard on it or really feel down when they don't meet it if they felt like they've been really trying to improve. Of course, we want our goals to be relevant. So does the goal really align with the overall facility plan? And then we want it to be time bound. So we want to give your goal a deadline so that we know when we want to have it completed by. So let's talk about specific goals so you can see how to make them. So if we are looking at hand hygiene, if our starting benchmark is we know that in pre-op, our hand hygiene rate was 65% over the last 6 months. Now we're going to try and write a goal to determine, at the end of the year where we want to get to. So the first goal we wrote, we're going to improve hand hygiene rates to 95%. We've got it relevant to what we're looking at, and we've also got it to be measurable. So to try and improve a little bit, we're going to make it have a time frame. We're going to say improve our hand hygiene rate to 95%, and we want to have that done in 2005. Again, we're relevant, we're measurable, and we're time bound. So better, but we still have some room to make this better yet. So a good goal would be to improve pre-op hand hygiene rates to 80% in 2025 through staff education and direct observation feedback. So we're saying here again that we want to focus on our hand hygiene. We know specifically that we're working on it in pre-op because that's where we've seen the lower compliance rates. We're going to change our goal from 95% to 80% because it's measurable, but it also is a little bit more achievable. And this isn't to say that 80% is where we want to end up, but it's a starting goal. And you can even break it up. Maybe you want to do 80% by, in 2025, and then by mid-2026, we want to get that up to 95%. So your goal doesn't have to be your end spot. It's just something that we want to do to work on this year. Still time bound, again, 2025. And we've also added some information in there about how we're going to do it. We're going to re-educate our staff, and then we're going to do direct observations, and we're going to give feedback on the spot when we see hand hygiene is not happening when it should. And then we're going to repeat this over again. So this is an ongoing process. It needs to be repeated for continued success. And the goal of your risk assessment is to just continually help move your program forward. You want to be always improving your infection control program, and it helps to see everything in a bigger picture and not just stagnate in your work. I know that, when you're in it and you're doing infection control every day, along with whatever other roles you have, sometimes it's hard to take a step back and look at your program as a whole and realize some of the bigger problems that you could be working on. And your infection prevention risk assessment is a living document. We want to keep updating it annually and then as needed if it grows and it changes with your program and the population that you serve. So at a minimum, it needs to be done annually, but we do need to make sure that we're updating it if anything changes or something new comes up. So when are some examples of times when we'd want to update it aside from that annual basis? So if we get a new surgical procedure at the facility, we would want to include that. Or if we get a new surgeon, even if they're performing a procedure, sometimes they want to do things a little bit differently. So we want to just explore that as well. If we have any new or emerging infectious diseases, of course, we saw what happened with COVID. We would want to consider it then. Even now with measles in the communities, that's a time when maybe we would want to update our risk assessment to be looking at what impact that could have. And then if we see an increase in issues with humidity and temperature in our sterile storage area, any change like that or any problem that's coming up, we want to make sure that we're including that. If it's happening now and we get it under control, we want to make sure in incoming risk assessments when we're looking at things that we don't let that slip on the wayside and we don't forget that that was an issue and make sure we're keeping up with everything that we should. So now we're going to walk through the whole process together. I'm hoping I laid it out pretty clearly, but just to reinforce, we're going to go actually through the process together. So what we have here is a completed risk assessment for a facility. This is obviously not all-encompassing. We're only looking at 5 different things, but this is what a risk assessment might look like. So this first one, we looked at non-compliance with our hand hygiene. I don't think any facility could ever assume that's never going to happen. We've marked it here as medium, that we think it's a pretty medium risk that we may have some non-compliance with hand hygiene. The impact for things like this can be hard to think about. Temporary harm, we could cause an infection to somebody who then may need antibiotics. But we could also create permanent harm or life-threatening harm depending on what type of infection the patient gets. And then what is our preparedness? On here we've said it's good. Maybe we're doing good education, we have signs up, but there's a little bit of work we could do. Maybe we want to make sure that we have hand sanitizer in more areas to make sure that it's accessible to everyone. We add up those numbers, we get a score of 4 for this. The next thing we're going to think about is our lack of compliance with the influenza immunization. Based on this here, we have it rated at a 3, so that would make me think that we probably have some pretty low compliance with influenza vaccines within the facility. The impact is probably temporary harm. We know that people can get really sick from flu. Hopefully it's just a temporary thing. And then how prepared are we for this? Maybe we're sending out information and we're offering the flu vaccine and that's it. Are we not doing more direct communication with staff or making sure that maybe we have multiple clinics that they can get the vaccine? So this one gives us a score of 6. Then looking at surgical site infections, we feel like this is a probability of not being very high. We rated it as a 1. We've had pretty good HAI rates lately. Obviously, the risk could be life-threatening depending on the type of infection, and we feel like we're really prepared for this. So we've scored ourselves a 4. The next one is improper pre-cleaning of instruments. I know this is an area that facilities I've worked in have struggled with. So with this one here, we've put it on a medium. Again, life-threatening. These are instruments that are obviously going to be reused. If we are not making sure that the pre-cleaning is happening, that is a huge step in making sure that we're able to effectively get rid of the bioburden on our instruments. So if that's not happening, we're really at a higher risk for getting a life-threatening infection. And how prepared are we? Maybe we know this is an issue, but we've put out some education, but not done a lot of work on it. So we end up with a 7 here. And then another thing is looking at worn, ripped, or torn equipment. So this is likely to happen. Maybe we've got high volume operating rooms and we've got a lot of patients coming in. So a pretty fair reason to assume that this is going to happen. The risk of the impact hopefully would be temporary harm. And then how prepared are we? We have rated good here. Maybe we feel like we've made this known to staff, and as soon as they see something, they pull it out of use and they let us know that we need to get it repaired or replaced. So we end up with a 4 on this. So based on these numbers, we know that lack of compliance with influenza immunization and improper pre-cleaning of instruments were our 2 highest rated categories. So those are the ones that we're going to use to create our goals for the year. So the first goal, the risk that we're trying to address here, is a lack of compliance with influenza immunization. When we look at last year's data, we see that we only had 67% of employees receive the influenza vaccine. If you are setting yourself up to have one of those spreadsheets that we looked at earlier that had 3 years worth of data, you can include that as well. Maybe we had 68% compliance over the last 3 years. So our goal is going to be to increase healthcare worker compliance with the influenza vaccine to 80%. These are our annual goals, so we know that we want to have this finished within this year. And then how are we going to do this? We want to really think about effective and doable ways to make this happen. So we're going to educate our staff and our surgeons on the importance of influenza vaccination. We're going to continue to monitor our influenza vaccination rates, and we are going to provide education to healthcare workers that are not in compliance. And we want to use evidence-based practices to increase compliance. So when we're thinking about these things, obviously we're going to educate staff on how important it is. And we're going to do that broadly to all of our staff. So maybe you want to look into the healthcare workers who aren't in compliance, having conversations with them about what exactly is going on. We may find out that they're actually getting vaccinated outside of the facility, and we just need to get proof from them that they're vaccinated. or we might find out that there are specific barriers or things that they're concerned about, and then we can try and find information and give them information to address their specific concerns. Our next goal then that we want to work on is our improper pre-cleaning of instruments. So we can use, last year we had 20% of our trays come to central sterilization with improperly pre-cleaned instruments. We want our goal to be to decrease the percent of improperly pre-cleaned trays coming to central sterilization down to 5%. The ways that we are going to do this is, again, we're going to educate our staff and our surgeons on the importance of pre-cleaning. We want to make sure that they know everything has to stay wet, what it should look like, that they need to have everything open so that it's being exposed to the pre-cleaning agent. Maybe we want to utilize the company's representative for additional education and bring that in. We can ask them to offer it at different times and different days. And this is especially something that we might want to think about if we have a lot of new staff that have come in since we brought the product in. Maybe they never got that training from the company representative. And we want to monitor and investigate all trays that are received that don't have proper pre-cleaning. And it's good if you can get staff to let you know when they've got the tray in front of them. You can see exactly what the problems are. We can also take pictures. A lot of times then we can send out pictures to staff to say, this is exactly what we're seeing. This is where, you know, we're falling below where we should in our facility. It might also help you identify exactly which ORs it's coming from, or if it's specific staff that are struggling with this, so you can have more targeted interventions. And then we want to post the tracking of all of that pre-cleaning data in staff areas. If there's anything we know about healthcare workers, they can be competitive. And if you can find a way, you know, obviously you don't want to post specifics about people, but maybe if you can post different subsets that are doing, you know, how they're doing, maybe ortho or, you know, urology and how they're doing, sometimes it helps to make it a little bit of a competition, and that can be motivating for people as well. So we've got our goals, and this is how we're going to lay them out and how we really want to look at them in a broad sense. So again, what is our risk? Lack of influenza immunization. The organization as a whole, our goal is to provide a safe environment for staff, patient, and visitors from exposure to influenza. In infection control, our goal is to decrease your exposure and infection by increasing our compliance with vaccination. We want to specifically increase compliance of our healthcare workers from 67 to 80%. We're going to do it through all of those methods we talked about: education, monitoring the influenza rates. And when we're monitoring the influenza rates, maybe we want to send things out more frequently. We may want to send out a weekly update to our staff managers or our administration so they can make sure they're staying on top of it. And then we want to provide education to healthcare workers who aren't in compliance, maybe specific to what their concerns are. We're going to evaluate it by reporting it to our infection control committee. And then who are the relevant participants in this? Obviously, the infection preventionists, all of our healthcare workers, administration and department managers as well, because it can be really helpful when we show that our leadership within the facility supports this goal. For our improper cleaning of instruments, organizationally, we want to provide excellent quality care without the development of surgical site infections. For infection control, we really want to optimize pre-cleaning practices for all of our surgical trays. Specifically, we're looking to decrease the percent of improperly pre-cleaned trays coming to central sterilization from 20% where we were last year to 5% this year. We're going to do this by educating our staff and our surgeons. We're going to use the outside company representatives to help us with our education. We're going to monitor and investigate any trays we find were not properly pre-cleaned, and then we're going to post this information so that we can show the staff how they're doing or how they're improving. If we're telling people this is a problem and we're asking people to do better, it's definitely helpful if they can see that their efforts are making a difference. We're going to monitor and report the percentage of improperly pre-cleaned trays to our infection control committee. And our participants are similar to the other one: infection preventionists, all of our healthcare workers, our department managers. I should have also included the administration as well. Again, leadership support is important. And then we get to the end of the year and we need to look and see how we did. So we're going to restate our goal. We wanted to decrease influenza exposure. We're trying to get it from 67% healthcare worker compliance to 80%. All of the ways that we did it with our education, we did do the monitoring, we did provide specific compliance or specific education to our non-compliant healthcare workers, and we ended up with a vaccine compliance rate this year of 83%. So we met and we exceeded our goal, which is great. Due to the importance of influenza vaccine compliance, it's going to be something that we're going to continue to focus on for improvement. With our next goal, though, again, we were trying to optimize our pre-cleaning practices. We wanted to get ourselves from having 20% improperly pre-cleaned trays to just 5%. We did all of our education, both in-house education and from the company's representatives. We monitored and we investigated in real time any trays that didn't get properly cleaned, and we did post all of that pre-cleaning data so that staff was able to see it as we were working on it. We got our percentage down to 8, so we didn't meet our goal, but that still is great and certainly something we can still celebrate with staff. Since we did not meet our goal, we're going to continue to focus on this for improvement. And so these things are going to go back when you do your next risk assessment. They will be back in the mix. With our influenza vaccine getting up to 83%, maybe it's not something that we decide to set a specific goal for next year. But of course, 83%, there's always room to improve on that. So we're going to still track it. We're going to still do that education. Now we've kind of worked it into our way that we push out our influenza vaccine, that we're going to continue having those conversations with healthcare workers who aren't getting the vaccine. As far as our pre-cleaning goes, we've gotten it down to 8%. Depending on how things score, this may end up being a goal that we continue to work on. What worked well, what didn't work well, what do we think that we can do better to get our pre-cleaning up practices to be more in compliance. And we want to make sure we're thinking about all aspects of this. We don't always want to assume that people aren't doing things because they just don't want to or they're lazy. It could be because maybe the product really isn't staying clean or isn't staying wet long enough to make it to where it needs to after it leaves the OR. Maybe we don't have the pre-cleaning product in a convenient place and staff have to go get it. So we want to really make sure that we are making it as easy as possible for our healthcare workers to do the right thing, because 9.5 times out of 10, they want to do the right thing. And then as an overview for all of this, we want to continue to have this as a process that we're going to do over and over again. We're going to assess our situation. We need to assess our community, our facility, what we're doing within the facility, what procedures we're doing. We need to identify the risks that we have within the facility. We're going to score all of them and decide which ones we need to prioritize. We're going to work on our mitigation strategies, and then we find ourselves back at the beginning where we're going to, again, assess all of our potential risks to see where we are after our first set of goals. With every presentation, we certainly like to introduce ourselves as your infection prevention advisors from the Patient Safety Authority. Currently, we have Joanne, myself, and Denise covering the state. We will have another IP joining us shortly, so until that time, reach out to any of the three of us. We are here for any of your infection prevention questions. We are happy to, come to the facility or even just call us for a quick question. We try to, if you have a new IP that you need someone to talk to, we're here to be a resource for that. We can also help with your infection control plans. We can help you with your risk assessment, especially if this is the first time that you're doing it. We do webinars like this, trying to get education out there. So anything that you may need as a facility, we are certainly here to help.
Thanks, Amanda. That concludes the slide presentation portion of our program. Now we would like to begin our question and answer period. We do have one question, Amanda. The question is, my corporate organization has one risk assessment we use for all facilities. Is this enough, or do I need to do something more?
So that is a question we get quite often. If you have a corporate organization that's giving you a risk assessment, talk to them about how you have to use it, but we definitely want to make sure it's great to use that as a starting point, but we do need to make sure that it is specific to your facility and your staff and your patients. It's not really helpful to anyone if we're doing it based off of something that's not relevant to us. So definitely go through that and make sure you have all of the risks that are relevant for your facility addressed. You can also, if you are part of a corporate organization, talk to other infection preventionists within that, umbrella and find out how they're doing it. Ask if they would be willing to share changes that they made. They may think of some risks that you haven't thought of, or maybe they have found ways to address risks that you haven't thought of as well. So certainly it's a great starting point, but make sure that you are amending it to be specific to your facility.
Great, thank you. We do have another question. How do we assess risk for diseases we haven't had in the facility but know are in the community, like TB or Candida auris?
So for diseases like that maybe we haven't seen, we want to make sure, even though we may pre-screen for these things and we aren't intending to bring them in, I'm sure we've all had situations where a patient shows up and they have symptoms they haven't reported or they didn't think to say something. So for illnesses like that, the Department of Health, the Pennsylvania Department of Health has some good resources where they track these things, and you can see not only what it looks like from a state level, but you can break it down to your county to see what that circulation is in your area, so you can determine that risk and how likely it is to come into your facility or how likely you are to see it and need to prepare for it. And that's a good way to know what you need to educate your staff on as well.
Great, thank you. We do have one other question so far. One of my problems is always compliance with PPE for isolation. What is a good way to measure that to show improvement?
So I think the best way to really measure something like that is get out there and make observations. If you know that you have got a patient that needs to be on isolation, sort of try and stand around and see what they're doing, see that we're putting on, gowns if we need to put on a mask, making sure that we're doing that when we go to see them. It's always best when you can really have that data. And if you feel comfortable with it, doing real-time feedback to say, hey, you forgot to put on your gown when you go in there. A lot of times what I have seen personally when I've been doing rounds and checking on isolation, what it a lot of times happens to be is like, oh, I was just going in to answer a question, I didn't put on my gown. Well, we never know when the patient's going to ask us to do something then, and the likeliness of coming back out, remembering to put on your PPE isn't always that great. Another thing that I see a lot of is if we're talking about gowns, maybe they put it on, but it's kind of hanging down, or they don't tie it in the back, which creates issues. So really making sure that they are not only putting it on, but putting it on properly. It's also always important to make sure that our leadership, our surgeons, any like lead nursing staff is following PPE too, because people are going to follow what they see their leadership doing. So really getting out there and doing those compliance checks is really important. If you have an issue where they know you're the infection preventionist and they're looking for when you're around to make sure they're doing the right thing, and especially we see this too with hand hygiene audits, you can get what we would call secret shoppers to do it, which is people that we're asking to make sure we're doing our compliance properly. A lot of times, if you have someone sitting at the desk, that's a good person to ask because they're kind of always there. That's their environment. They can make observations without people recognizing that that's what's happening. And then sometimes those people are willing to do direct feedback as well, and sometimes they're not as comfortable doing that. So that's something you have to feel out as you get a program in place.
Great, thank you. The webinar will soon be ending, but we do have time for a few more questions before we end the program. We do have another question that just came in.
Okay.
What are your thoughts on using UV?
My thoughts on using UV. You know, I would have to look into UV a little bit more. I know I worked at a facility years ago and we used UV for some of our harder to eradicate organisms, such as C. diff. We made sure that we did that as part of the terminal cleaning. I will look up some more recent research and see what I can find. I know that's been sort of a mixed bag. I think things to consider with using UV is what you want to use it for, how often you're going to use it, and making sure that staff are able to actually do it. The other thing, which was something that we dealt with to consider, is how long the UV process is going to take, if it's going to delay turnover of your rooms and what that's going to mean. So I have been in institutions that have used it and institutions that have not. I will look a little bit more into some of the more recent data to give you a more formal opinion on my thoughts on it. But there are things to consider. The other thing is the education with it. That was something else that we struggled with. If you're using UV, you need to make sure that everything is exposed to the UV. We've had that before. I've seen it too with facilities will buy the little UV boxes where staff can stick their phones into. But if you stick a stack of 5 phones in, everything in between, or all those phones in between that aren't actually getting contact with the UV, are not being cleaned. So it can also make staff feel safer because they think a room has been completely UV'd. But if we're not doing it properly and making sure that the UV is hitting all areas, that can be a limitation as well. So just another thing to consider when you're thinking about using UV. You're welcome.
If it's okay, I would just add my experience with UV as well.
Yeah.
I worked at a facility where it was implemented as part of a C. diff initiative, and there were lots of other things going on. Yeah, lots of other things going on at the same time. And there was a reduction in C. diff over time. Eventually, the machines did break and weren't replaced, and we did not see an increase in C. diff when that happened. So I think it's a tool that can be used to help, but I think kind of what you said, Amanda, too. Sometimes if we rely too heavily on it, I don't know that it's as effective as the good old cleaning and disinfection and, using the other products that we do have in place. So just my 2 cents as well.
I think that's a good point too, Denise, because if you are concerned enough about something that you're investing the capital to buying the UV machines, you're probably doing a lot of other initiatives at the same time. When we were working on it with C. diff, we were also working on ordering practices and making sure that we were collecting a sample as soon as someone had symptoms. And so it's really hard to tell what was due to the UV and what was due to all of the other initiatives that we had in place. So does UV work? Does the science work in general? Yes. How does that work out in the real world is harder to assess sometimes.
Great, thank you.
One other thing, if we don't have another question, that I wanted to talk about within my presentation, and I touched on it a little bit, but I just wanted to reiterate. I think the value of the information we can get from our staff and not just our leaders is really important when we're thinking about all of our risks and getting everyone's opinion. So even things like when we're looking at one of the risks that we're probably going to look at is our respiratory hygiene, coughing etiquette. Talk to the people who are at your registration desk. Do they have signs that are up there? Do they offer masks to people if they see that they're coughing or that maybe they're sniffling a little bit? Do they have tissues out there? And then are people accepting them? Especially during, obviously, the respiratory season, but talk to the people who are actually there and seeing it. and finding out, what is going on and what we can do better, because sometimes there's simple solutions and the problem's not as big as we thought it was. Like I mentioned with the flu vaccine, if we've got a low compliance rate, but then we get out there and we talk to people, maybe it is that they are getting vaccinated. They're just getting it done at their local CVS because the time that we're offering it or the clinics that we're offering aren't convenient for them. And, that's a really easy fix. We don't want to spend our time re-educating on things when we find out we just don't have the proper forms collected and that they really are getting vaccinated. So make sure that you are really getting out there and talking to everyone, because that's how you're going to make sure that you have the most reliable information to perform your risk assessment.
At this time, I'm not seeing any additional questions. I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to reach out and direct any inquiries to Shelley Mixel at shmixell@pa.gov. This concludes our webinar.